Hello, good afternoon, everyone. Hello, I hope you can hear me.
Hi, good afternoon. Yes, you are audible, Ibrahim.
That's fine. Happy to see all of you guys. I don't know if you can commence the meeting.
Yes, please, let's start.
Okay, good afternoon once again. I'm in a person of Ibrahim Boahin, a physiotherapist and a health tutor with the St. John of God College of Health. As we are all aware, today happens to be a learning experience for all of us. We have our resource personnel in the person of Mr. Steven Say, a graduate from the University of Health and Allied Sciences, who currently is having his mandatory internship with the Anglo Gold Ashanti Foundation in Obuasi. Without much ado, I think let me hand over to Mr. Seven if he's on board now, so that we can commence the meeting.
Thank you very much, Mr. Host, Mr. Michael Abwaji. I'm very grateful for this opportunity given me to share my little knowledge in radiography with you. I'm very grateful. And welcome all of you on board. We hope that today's session will be very interactive. And then whilst the meeting or the session is going on, you can put in your questions in the chat box. Okay. All right. So without wasting my time, I want to share my screen. Please, can you hear me?
Yes, you are very audible.
All right. So I'm sharing my screen. All right. So once again, you're welcome. And then as the topic for today's session is, it's about chest radiography and mainly chest X-ray evaluation. That's how to read chest X-ray images. All right. So this is mainly today's session, and that is what it's about. So with an overview, today's session, we'll be looking at the basic radiographic densities. Then we move on to the X-ray or the chest X-ray anatomy. You have to know the various parts of the chest X-ray so that it will help you to make the right reading or interpretation of the images. And then we move on to the various views that we have for chest X-ray examinations. And then we assess the technical adequacy of every image. So before you do the systematic reading of any X-ray image, you have to know the technical adequacy or the diagnostic quality of every image of the image, or you have to know the technical adequacy so that it will help you to know or Can you hear me?
Yes, sorry, we can hear you now. The line went off.
Yeah. So just as I was saying, I was talking about the overview for today's session. All right, I hope you heard me right, or you heard me clearly about the overview, or I should go over again. So with respect to today's session, we'll be looking at the basic radiographic densities, then we move on to the chest X-ray anatomy, then we do understand how the various chest X-ray images are viewed, and then we look at the technical adequacy of every image. That is, before you can make meanings or before you can read every chest or every X-ray image, you should be able to know the technical adequacy of that image before you can make meanings out of that image, okay? And then we tackle today's task, which is the systematic review of the chest radiograph. So throughout this session, I'll be interchanging the words X-ray image and then radiograph. Actually, radiograph is the right word to say because radiographs are actually the resultant image that are produced and then printed on X-ray films, or we are in the digital world. So the X-ray images that we see on our screens, those are the radiographs. And I think that is the right word to use for X-ray images, okay? So to start with, let's look at the basic radiographic densities. Whenever we are given an X-ray film or a radiograph to read, all that we mostly see are, or the things that we see are dark and white shadings on the film. Actually, these dark and white shadings on the film, they correlate or they correspond to the various anatomies within the area of interest or the part that we are reading, okay? Example, when we are given a chest radiograph or a chest X-ray image, mostly we see the white, the black, and then the gray areas. These are shades of gray, okay? And they represent the various structures within the chest region. So example, we have the heart in there, we have the bones, we have the lungs, we have the diaphragm, we have the liver. All these have the way they appear on the radiograph. So the basic radiographic densities will help you to know how the images or how the structures within the chest or within any part of the body appear on the radiograph. So now let's look at the first radiographic density, which is air. Air appears dark on the radiograph. And before that, let me check this in. The various shades of gray, they are the densities that we see on the radiograph, okay? And they actually come out as a result of attenuations of the X-rays when they are exposed to the parts that we are imaging. This one is not a radiography webinar, so I don't want to bore you with the technicalities within radiography, okay? But when we say attenuation is mainly about how the X-rays are absorbed, scattered, or transmitted through the body parts, okay? So this absorption and then transmission of the X-rays will give us the basic or give us the radiographic densities that we see on the radiograph. So to start with, air, as I said earlier, they appear dark on the radiograph because with air, there is no absorption of the X-rays. So the X-rays, all of them pass through to the image receptor to form the image. And then, so it means that whenever we see dark areas on a radiograph, it means that that structure or organ contains air. So example is the lung on a chest X-ray. So it means that the lung, which is an air-containing organ, will appear dark on an X-ray film or a radiograph. Then we look at dark gray. There are certain areas on an X-ray image that appears dark gray, okay? And then example of these areas or structures within the chest radiograph that appear dark gray are the subcutaneous fat or mainly adipose tissue structures, okay? Structures that contains a lot of fat, okay? Then we have light gray. There are areas that appear light gray on an image or X-ray image. These are mainly the soft tissue structures. So examples, we have the heart, we have the liver, the diaphragm, they are all soft tissue structures, and then they appear light gray on the chest radiograph. Then we have whitish areas on the radiograph. So example, we have bones. Bones appear white on radiograph because they absorb much of the radiation when they are being exposed to them. All right. So whenever you see white areas on the chest radiograph, it means that you are assessing or you are seeing the bone. And then we have other areas that appear very, very, very white. It is whiter than the bones. And these are mainly metallic structures. So whenever you see a foreign body such as a coin or someone has swallowed a coin or any metallic structure, and then you do an X-ray on that person, the resultant image, you will see a very bright white structure within the location or where you find that foreign body. All right. Please, I hope you've understood up to this part, or should I go over?
So please, we understand.
All right. So let's move on. So having understood the basic
explanation is fine.
All right. Thank you very much. So let's proceed. Having understood the basic radiographic densities, mind you, these are basic, okay? As we move on, we'll get to know a lot. So having understood the radiographic densities, let's move on to the chest X-ray anatomy. Anatomy is very important in X-ray reading. Without anatomy, you wouldn't be able to make any meaning out of the image that you are handed to. So it is very important to know your anatomy, the radiographic anatomy very well, okay? And then let me pass this disclaimer. For the purpose of this session, we'll be dealing with the standard chest X-ray, which is the PA view, that is the posterior anterior view. We will come there, but I just want to pass this disclaimer so that whenever we see an image on the screen that I've shared, it means that we are assessing the posterior anterior X-ray image. All right, I hope you've understood that.
Yes, sir.
Yes, please.
Okay.
Yes, sir.
So now, an overview of the chest X-ray anatomy. It is very important, just as I said earlier. So let's do a little bit of the part and then we proceed because of our time. All right. So as I said earlier, with respect to the basic radiographic densities, any dark shading within the radiograph represents an air-containing structure or air-containing anatomy, okay? So let's start medially. Let's look at, I hope you can see my cursor.
Yes, please.
Yes, sir.
We can.
Yeah. So the place of the cursor is the trachea, all right? Then the normal positioning of the trachea is a little bit shifted right, okay? It is a little bit shifted right, okay? Or it is centrally placed. That's the trachea. The reason why it is slightly shifted to the right is because of the presence of the aortic knuckle or the aortic arc here. We will get there, so let's move. When we trace down the trachea to the carina is actually the point of bifurcation of the trachea. So it means that the trachea, as it comes down, it bifurcates into two parts. That's the right and left main bronchi. Then the right and left main bronchi move or enter the lungs through the carina. So the carina is the point of through the hilum. So the hilum is the point of entry into the lungs, okay? And then within the hilar region, so hilum is singular, and then hilar is plural, all right? Within the hilar region, we have different structures in there. Aside the main bronchus entering the hilum, we have pulmonary vessels also entering the hilum into the lungs, okay? We also have lymph nodes around the hilar region, all right? Now, let's look at the lungs. The lungs appear dark. Just as I said earlier, it is an air-containing structure, so it appears dark. Okay, the lungs, the very topmost part of the lungs is called the apex. Okay, and then we have the very bottommost part of the lung, which is the base of the lung, right? And then within the lung region, we are having the ribs. Okay, so these, the place where I'm pointing or where my cursor is, this one, that one, or this, they are all ribs. Okay, and then on a chest X-ray image, it is very important to be able to differentiate between the two ribs. We have the anterior ribs and then the posterior ribs. The anterior ribs, look at how they appear. It is very important to know the appearance of the anterior and posterior ribs. The posterior ribs, they are more or less like there's convexity. It's more of like convex shape. And then we have the anterior ribs, like, and it is more concave, okay? And it is more oblique. So it is important to differentiate between these ribs, which will help you in reading the chest radiograph. All right. So when we come to the bones, also still with the bones, because the rib is also a bone, we have the clavicle. The clavicle, we have part of it. We have the medial part, and then we have the distal part. And then we have the scapulae. We have the left and then the right scapulae in there. Okay, now let's look at the heart. It is very important to know the position of the heart, because when the heart is out of position, you should be able to know that, yes, there is something that is causing mediastinal shift, because the heart is within the mediastinum. Okay, so look at the position of the heart. This is the normal position of the heart on every radiograph, on every normal radiograph. All right, so the heart has borders. We have the left and then the right borders. The right heart border is mainly formed by the right atrium. Okay, and then we have the left heart border, which is mainly formed by the left ventricle. Then we have a little bit of the left atrial appendage, just superior to the left ventricle. All right, so having known the position and then the various parts of the heart, let's move on to the diaphragm. On a chest radiograph, the diaphragm is divided into two. We have the left and then the right hemidiaphragm. Okay, so this one is the right hemidiaphragm, and that one is the left hemidiaphragm. And then the hemidiaphragms, they form an angle known as the costophrenic angle with the lateral aspect of the chest. Okay, so this is the lateral chest wall, and then the hemidiaphragm. So this angle is known as the costophrenic angle. I think we've covered enough of the anatomy. And by the way, please, I hope you've understood the anatomy a little bit. This is just an overview, okay? There are a lot of materials out there which can help you to actually understand the radiographic anatomy of the chest. Okay. Or I should go over it again. Please, are we okay?
For now, yes. I want to know,
please.
after the delivery, then we give time for question and answers, or as and when someone gets a question, the person after, then that is fine.
All right. Okay. So now let's move on. Chest X-ray examinations, we have various projections or views for them. Okay, and it is very important to know the various views of chest X-rays. We have the posterior anterior view, which I said earlier. We have the anterior posterior view, and we have the lateral view. The posterior anterior view means that the X-ray was taken with the patient's anterior part, or the patient facing an erect backing. Okay, so it means that the radiation was introduced to the posterior aspect or the back of the patient, and then it's exited through the anterior part of the patient. That's how come we get the PA, or the posterior anterior view. Then we have the anterior posterior view. The anterior posterior view, or the AP view, is also done by the patient's back against the erect backie, or the X-ray is introduced to the anterior part of the patient and then it exits through the posterior. All right, and then we have the lateral view. It is very easy to know that this image is a lateral chest X-ray, okay? But however, let's focus on how to differentiate between the posterior anterior view image and then anterior posterior view image, okay? The posterior anterior view, how to differentiate them. Mostly, it is difficult to differentiate the two, but we look at certain things to make the differentiation good enough, all right? When you look at the posterior anterior view image, mostly the clavicle, example is this. Example of a posterior anterior view image is this. Mostly the clavicle helps us to know that yes, this one is the posterior anterior view image or an anterior posterior view image. When you look at the clavicle, on the posterior anterior view image, the clavicle moves or looks more or less like an S shape, okay? This one, the image is being cropped, so you can't really appreciate the entire length of the clavicle. But on the PA view, the clavicle is more or less like an S-shaped appearance, or it has that S-shaped appearance. However, on an AP film or AP view image, the clavicle is more horizontal. You see how this one is appearing on an AP view or AP image, the image is more, or the clavicle is more horizontal, or it lies in the horizontal plane. Also, we use the scapulae, the two scapulae. All right, that's the plural. Singular is scapula. We use the two scapulae to differentiate between a PA and then an AP image. So for a PA image, it means that the patient is very capable, the patient is very strong, and then the patient was able to stand to do the image or to do the radiologic examination. So on PA film, the scapulae are always out of the lung fields. It should never be seen within the lung region. All right, see how, or see the position of the scapula. The two scapulae, they are very off the lung fields. However, on an AP film, because the patient, or the AP film is mostly done on patients who cannot stand to do the standard chest X-ray examination. So mostly the patient lies supine or the patient is sitting. So with that, the patient cannot rotate the arms to clear the scapulae off the lung fields. So mostly we have the scapulae overlying the lung area or the lung region. Okay, so I think basically these two structures that I've made mention of, that's the clavicle and then the scapulae, should help you to differentiate between the AP and then PA films. Okay, there are more. We have the appearances of the ribs too. Okay, and also the number of ribs that you count are also important when we are differentiating between the PA and an AP film. We will get there. So, and then lateral view, it is very easy to know that this one is a lateral image or lateral radiograph. Okay. So having understood or known the various chest X-ray views, let's move on to how to assess the technical adequacy of every X-ray image. The technical adequacy of an X-ray image assessment, okay, helps you to know that whether the image has that diagnostic quality for you to proceed with its reading. So it is very important to assess the technical adequacy of any X-ray image when you are going to read the image. Okay, that's the first thing to do. You look at the technical adequacy of that image before you proceed with the systematic review or the pathology search. Okay, so with the technical adequacy, there are a lot of tools out there that will help you to analyze or to assess the technical adequacy of every chest X or every X-ray image, okay? But I chose the Paceman. The Paceman is kind of easier, and then it is quite easy to memorize, okay? So the various letters within the Paceman, they all have meanings, where P stands for position, A stands for area, C stands for collimation, E stands for exposure, M stands for marker, E stands for aesthetics, and N stands for name. So with the position, there are criteria to assess the position, okay? So you look out for inspiration. You ask, did the patient really do the inspiration very well, okay? And then the inspiration is assessed by counting the reps, okay? So when you are counting the reps, you count, let's see, this one is for a normal X-ray film, and then in a PA view, okay? So you should be able to count at least 9 to 10 posterior reps above the diaphragm. That is when you know that, okay, the patient really did the inspiration very well, okay? When there is poor inspiration, the image assessment is very difficult, and also it will also lead to making poor diagnosis or misdiagnosis, which can also affect the patient's management, okay? Because when there is poor inspiration, the heart size becomes deceptively enlarged, and there is also crowding of the lung markings or the pulmonary vasculature at the base of the lungs, which will obscure any subtle abnormality within that area, and also you make wrong assessment of the heart too. So it is very important to make count the reps to ensure that the patient really did the inspiration very well. All right. And also, for still on the position, we have clear lung fields. When I say clear lung fields, I'm talking about the scapula being moved away from the lung region. All right. So it means that on a normal PA film, the scapula should be out of the lung fields. Then you look out for rotation, still on the position. You look out for rotation. It is very important to assess whether there is rotation in the chest X-ray image or not. And how do we assess the rotation? Rotation is assessed by measuring the distance from the spinous process that is adjacent to the medial aspect of the clavicle. All right, so this one is the spinous process. You see, there are little dots within the trachea, okay? These dots, things that we see, they are the spinous processes, okay? So the assessment of rotation is measured by, or is done by measuring the distance from the spinous process to the medial aspect of the clavicle. You measure for both sides, the left and then the right, then you compare the distance. When the distance are equal, it means that there is no rotation. However, when there is when there are differences within the distances or the two measured distances, you know that there is a rotation, okay? And rotation can cause significant shift of the trachea, all right? And significant shift of the trachea can mimic other pathologies. And then due to poor positioning and then rotation within the image, we can make poor diagnosis or misdiagnosis, and we can actually conclude that the significant shift of the trachea is as a result of a pathology, which is not. Okay, so it is very important to assess the rotation. And for a normal PA film, the rotation should be minimal. Okay, yeah. So still on the Paceman, let's look at the A, which stands for area. So you ask, are all the relevant anatomy or are all the relevant parts of the chest X-ray showing on the radiograph? So that's where you look at the borders of the radiograph. You look at the superior border, you look at the two lateral borders, you look at the superior border, okay? You look at the two lateral borders, then you look at the inferior border, okay? So the superior border, you should be able to see the sit and sixth or seventh spinal process of the cervical spine, okay, of the cervical vertebrae. All right, that's for the superior portion. So it means that the spinal processes of the sixth and seventh spinal process of the cervical vertebrae should be shown at on the lateral, or sorry, on the superior part of the chest radiograph. Then we come to the two lateral borders. You look out for the lateral skin margins, the part where the cursor is pointing. Right, these are all the lateral borders, and then this one is the skin margin. So this is a skin. This one is also a skin. So we look out for them. And then the inferior border, we have the costophrenic angles. They should always be there. So when you see an image where the costophrenic angles are not showing, it means that the patient, or it means that the image is not quality, or the image is not good enough for reading or for systematic review or pathology search. Okay, you should be able to see all the regions or the borders around the chest X-ray image. All right, please, are we okay? Can I continue?
Yes, we are following small.
Yes.
Small.
Yes.
Someone said small. Okay, let's continue. But I hope you've understood to this part, the area, all right? I hope you've understood the area.
Yes, please. Yes.
All right. Okay. Now let's move on to C, which is collimation. So you should be able to see evidence of collimation on the image. Okay. Evidence of collimation, they appear, these are the white areas along the borders of the radiograph. Okay. And mostly we don't usually see those evidence of collimation because of the post-processing. Because of the post-processes that we do to our images before we print them out. So we clear or we cut off those evidences or those white areas of collimation away. So you don't usually see them. Now let's look at the E. E stands for exposure. So you ask, is the image optimally exposed? Okay, so optimal exposure is actually assessed by looking at the heart shadow. Okay, when you look closely at the heart shadow, there should be the presence of the thoracic spine running faintly behind the heart shadow. So when you are able to see that faint thoracic spine within or behind the heart shadow, it means that the image was exposed adequately. Then we look at the markers. It is very important to locate anatomical markers because they will guide you to know whether you are assessing the right part of the image or not. So when I say like the right, I'm not talking about like left and right, like the correct part of the image, okay? So anatomical markers are very important. An example of an anatomical marker is this thing. So this one, L, means left. So if it was supposed to be right, it means that it should be R, all right? Then we look at the aesthetics. Aesthetics is actually the beauty of the image. So you look whether the image is centrally placed within the X-ray film, and then the beauty of the image is also dependent on all these things that you've said before the aesthetics. That's the position, the area, collimation, exposure, and markers. They contribute to form the beauty of the image. So when you look at all these parameters or criteria that we've talked about earlier, and they fall within the normal range or they are okay, it means that the image is automatically beautiful. The N stands for name. So on every radiograph, you should be able to see the relevant patient identification details, such as the name, the age, and other details. Okay, it is very important because the name will help you to know that you are assessing the right image for the right patient. That is very, very important You don't want to make diagnosis for the wrong patient, and that one can lead to a lot of detriment on our profession. And we wouldn't want to involve ourselves in that. Okay. All right. Please, are we okay with the technical adequacy of the image, the paceman?
I want you to explain on exposure. I did not get it due to the network.
This you said?
I said I want you to explain on exposure. I did not get it clearly due to the network that is disturbing. Please.
Oh, okay. So I talked about exposure, and I said that you should ask yourself whether the image is rightly exposed or the exposure is optimal, okay? And then optimal exposure is assessed by looking at the heart shadow. When you look at the heart shadow, okay? When you look at the heart shadow, let me use this image. When you look at the heart shadow, you should be able to see a faint appearance of the thoracic spine. You see all these things, their spine, okay? You should be able to see the faint appearance of the thoracic spine within the heart shadow. This means that the image is optimally exposed. Please, do you get it now?
Yes, thank you very much.
All right, so now let's proceed. I hope we are all okay.
Yes.
All right. So now let's proceed. This is a normal chest radiograph, okay? And then with all that we said concerning the technical adequacy assessment, let's try and use the various parameters that I talked about earlier. That's the paceman to assess the technical adequacy of this image, okay? So now I talked about P, which is position, and I talked about the criteria to assess the position, which include inspiration, clear lung fields, and then rotation, okay? So the inspiration, I talked about counting the reps to know that, yes, the inspiration was adequate or good enough for further assessment of the image. So, and I said earlier that on a normal PH chest radiograph, you should be able to count like 9 to 10 posterior reps and at least 5 to 6 anterior reps, okay? This will help you to know that, yes, the inspiration was adequate. So let's count the posterior reps. So it is very important not to miss the first posterior rep, because most of the times we miss it because of the superimposition that happens in there, okay? So now let's count. This is the first one, okay? This is the first, sorry, this one, this is the first posterior rep. This is the second, this is the third, this is the fourth, this is the fifth, this is the sixth, this is the seventh, eighth, ninth, and then the 10th. Always, when you are counting the reps, the ones above the diaphragm is what is included in our counting, okay? Those below the diaphragm or within the diaphragm region, they are excluded. So this, we had 10 posterior reps. So it means that our image is optimally, the patient did a very good inspiration, all right? And that is what we want in our radiographs or in our chest radiograph. Then we talked about clear lung fields. So clear lung field, that's where I talked about the scapulae, the two scapulae being off the lung areas, all right? So look at where the scapula, the right scapula and then the left scapula is. They are off the lung fields. And then we also talked about rotation, where I said the rotation is assessed by measuring the distance from the spinous process adjacent to the medial aspect of the clavicle. So when you measure the distance from the spinous process to the left clavicle, and then the spinous process, the distance from the spinous process to the right clavicle, the distance should be equal. It means that the rotation, there is no rotation in the image, okay? All right. Then we moved on to area. Then we talked about whether all the relevant anatomy are included within the chest radiograph, okay? Where we said we look at the superior borders, the two lateral borders, and then the inferior borders of the image. So the superior border, you should be able to see the spinous process of the 6th or 7th cervical vertebrae. Okay, and then you look at the lateral margins or the lateral borders where we have the lateral skin margins. Okay, then the inferior borders, you look at the costophrenic angle. They should always be present. They are very important. So now, I want to ask, are we okay with the technical adequacy assessment? Please, your reviews are very important. It will help me to know whether we are making progress or not. Please, are we okay with
Please, I want to find out. So does it means that this X-ray was taken posterior anterior, right?
Yes. So I said earlier that all the images that we will see on this image or in this session, they are posterior anterior images, because posterior anterior images are the standard view for chest X-rays. Okay.
All right. I was a bit confused. The way I still see lefts at the top, I was a bit confused.
All right. So I'll tell you the reason why we are seeing left the L there. All right. So now let's proceed. You get to understand it. Now let's look at the collimation, which is C. We've talked about the area. So let's look at C, which is the collimation. So we should be able to see evidences of collimation around the image. However, this image is a processed image, okay? So we've cropped off the area of collimation, all right? And that's what is mostly seen in on our images, because most of our images, they don't come out raw just like that. They come out processed or manipulated. So you have all those evidence of collimation chopped off. Now let's look at the exposure. We said that the exposure is assessed by looking at the heart. You look through the heart, you see the thoracic spine within the heart. Okay, then the marker. So the reason why you are seeing left here, which is this part, this is the marker. The reason why you are seeing left there is that we always review or read an X-ray image as if the patient or as if the patient was standing in front of you. So just assume that the patient or someone is standing in front of you face to face. The patient's left will be your right, or the person's left will be your right, and the person's right will be your left. Please, do you get me? Hello?
Yes, I get it.
Yes, so the images or every X-ray image is read as if the patient was standing in front of us face to face, okay? So the patient's left will be our right and the patient's right will be our left, just like that. So that's the reason why we are having L, which is left on the right side. So when it's on our right side, okay? All right. So now let's proceed to today's task. So having gone through the technical adequacy assessment of the image, then you come on to the pathology search. That is when we use the systematic approach. Okay, it is always very important to review all your images systematically, because we wouldn't want to miss any subtle pathologies, okay? We wouldn't want to miss any subtle pathologies, okay? So that we base our diagnosis only on obvious abnormalities, okay? So this approach, they are actually mnemonics. There are a lot of them. There are a lot of mnemonics out there that we can use to systematically evaluate our images. However, I always like to use the A, B, C, D, E, F, G, H, and S approach. It is very easy, and it is also very easy to memorize. Each of the alphabet, we have meanings, just as the paceman that we did earlier. All right. So now let's look at the meanings of the alphabet. A stands for adequacy, and B stands for bones. C is for cardiac, D for diaphragm, E and F for equal length fields, G for gastric bubble, and then great vessels. Then we have H for hilar and then mediastinum, then S for soft tissues, and then other structures or other medical structures or other foreign bodies that we will see, okay, or any other thing aside the lumbar anatomy that we will see within the chest region. Please, are we okay? Should I go over it again? Hello?
Yes, sir.
All right. So now let's proceed. Let's start with the A, which stands for adequacy. So just as I said earlier, it is very important to evaluate the technical adequacy or the diagnostic quality of every image before we proceed with the pathology search. So that's how come we started with A, which is adequacy. So with the adequacy, we talk about paceman. We've talked about it earlier. We looked at the various parameters in assessing the technical adequacy. Okay, so with the paceman or with the adequacy, you look at the view. Is it an AP? Is it PA or a lateral image? Look out for adequate inspiration, which the paceman will help us to do, and then also you look out for rotation, any possible rotation within the image, and then adequate exposure or penetration, just as we use the paceman to do. I hope this part we've already covered it with the paceman or the technical adequacy assessment, the one that we did earlier. So we can proceed. B stands for bones. So it means that for the B part, we should be able to evaluate anything bone within our chest X-ray image. So the bones within the chest X-ray image, we can find the clavicles, we can find the spine, we can also find the scapulae, the two scapulae, the left and right. We can also look at the ribs, okay? It is very important to evaluate the bones. Why? Why? Because we look out for fractures and lesions that can occur within the bones, okay? So we check whether there is fracture within the bones or other pathologies affecting the bones. So how do we assess for fractures? Fractures are looked out for by tracing the cortices of the bone. Okay, so now let's look at a bone cortex. So a bone cortex is actually the outermost part of the bone. It is very, very bright white compared to the middle part of the bone, which is the trabecula. All right. So this one is the cortex where the mouse is pointing. That is the cortex. That's where I'm tracing. Look at the clavicle, the right clavicle, tracing it down, tracing it down, tracing it down. That is the cortex. Okay. And it comes. That's the superior part. That's the inferior part where the mouse is pointing. I'm tracing it up, tracing it up, tracing it up. Yeah. So that one is the cortex. Okay. So you trace, you look out for each bone, then you do the tracing. Trace all the cortices of the bones to rule out for fractures. How do we see when there is a fracture within the bone? When you are tracing the cortices of the bone, and you get to a point where there's discontinuity along the way, you pause and you get to know that, yes, that part is fractured or there's a fracture within that area. Please, hope you get me.
Yes, please.
Yes. So you trace the bone, you trace the cortex. You see where I'm drawing? That green line that Those are the quarters. Yes, those are the quarters. Okay. So those are the quarters. So when you see discontinuity, you see there was like that free flow whilst I was drawing along the line. Okay, so when you see that there is a breakage or there's a discontinuity, then you should call in for further evaluation, and you should tell you that yes, that part is fractured. All right. All right. Okay, now let's continue. There are other lesions or other pathology aside fractures that can also occur to bones. Okay, there can be a situation where the bone will lose its opacity or will lose its density, that white appearance, and becomes kind of dark, okay, or becomes a little bit dark. Yeah, so these are other pathologies that can affect bones, and these are mostly osteoporosis, where the bone lose its densities, or other bone infections that can cause reduction in the calcium intake that can also affect the bone density. We also have discrete lesions or lytic lesions, LYTIC. These can also affect the bones, and they are actually seen as a result of they can be as a result of discrete radiolucencies within the bones. Okay, when we see areas within the bones which is supposed to be white, and then we are seeing areas of small, like very small dark area within that bone, it means that we are having a lesion. Okay, please, I hope you've gotten me and we are okay. Please, can you get me?
Yes, sir.
Yes, please.
And I hope you've understood too.
Yes.
Good. Now let's move on to the C. Let's move on to C, which is for cardiac. It means that anything relating to the heart that we see on the radiograph, we should assess them. So the cardiac, we look at the heart size, we look at the shape and the position. Okay, the heart size is assessed by using a mathematical formula, which is the cardiothoracic ratio, and that ratio, it is the ratio of the cardiac weight or the heart weight to the thoracic weight. Okay, just as I've spelled it out here, it is the ratio of the cardiac weight to the thoracic weight. And for a normal PA field, where the patient is not having any abnormality with respect to the heart, the normal range or the normal CTR or the cardiothoracic ratio should be less than or equal to 0.5. Or when you want to do it in percentage, it means that you're going to multiply the fraction that you get here by 100, where you can get your percentage value. Okay. The normal heart size for a normal PA field should be less than or equal to 0.5 or less than or equal to 50% when we are to mention it in the percentage. So it means that any value above 0.5 or 50% means that the heart size is increased or the patient is having heart enlargement, which is termed cardiomegaly. Okay. All right. However, in a situation where the patient cannot stand to do the PA field or the PA chest X-ray, but it is important to do a chest X-ray for the patient, we do an AP projection. And I've made mention of how the AP view is done or the AP chest X-ray is taken. For that one too, we can also measure the cardiothoracic ratio. But here is the case: the AP film is not the standard chest X-ray film. I've made mention of that earlier. The standard one is AP. The reason why AP cannot be the standard for assessing the heart size is that whenever we are taking the PA film, the patient's back is always against the image receptor, and then we shoot from the anterior part, then the radiation exits at the posterior. So it means that the anterior thoracic structures are always above or further away from the image receptor, okay? And then the thoracic structures, we have the heart in there too. So it means that, and then in radiography, the further an object is away from the image receptor, the more that object becomes magnified, okay? So when the heart is away, as in the case of an AP film, it means that the heart becomes magnified. But here is the case: we have no option than to do an AP film, and we have to also assess the heart size. There's a value. The value is a little bit higher than the AP, than the PA film, okay, the normal size. In this case, we are having less than or equal to 0.6 for the CTR in an AP film, or 60%, less than or equal to 60%. Okay. Please, I hope you've understood that the two differences in values. Can I proceed?
Yes, sir.
Okay. And also along the heart. All right, so this is the right demarcation of the heart. You see that green area? That's the heart, okay? Also, you should be able to assess the you should be able to assess the cardiophrenic angles. All right. When I said costophrenic angle earlier, I made mention of how it is formed, and we said that it is formed by the diaphragm, and then the diaphragm, and then the lateral chest wall. Okay, this angle is the costophrenic angle. And in the case of a cardiophrenic angle, it is formed by the heart border and then the diaphragm. Okay, so this angle, let me try to annotate. So this angle, and that. These two angles, they are the cardiophrenic angle. So it means that it's an angle that is formed by the heart border and then the diaphragm. It's always important to look at those areas for any pathology or any radiopathies within those areas. All right, because some pathologies can be very stubborn, they can hide within those areas, and it is very important to look at those areas to fish out or to rule out those pathologies so that you don't miss them. All right. Also, it is important when you are evaluating the heart, which is C, the cardiac, to look out for any calcifications within the heart or medical devices such as the prosthetic heart valves. All right, we can have a patient who will come in with a prosthetic heart valve. Okay, the normal heart valve is replaced with an artificial one. So you have to be able to know all these. All right, so now let's proceed and then move on to D, which is the diaphragm. The diaphragm is always important to look at. And so you have to assess the position and then the shape of the diaphragm. They are very important. How do we look out for the position of the diaphragm? The position of the diaphragm, always the right hemidiaphragm is a little bit higher than the left hemidiaphragm. It's about 2 centimeters higher than the left hemidiaphragm. Okay, so in a case where there is a significant elevation of the height of a diaphragm, you should look out for the pathology that is causing that elevation. It could be as a result of paralysis in the phrenic nerve, okay, which is causing that eventuation to occur in the diaphragm, or it can be as a result of, let's say, the patient is having hepatomegaly, like enlargement of the liver, and then it's causing a push of the diaphragm upwards. Yeah, that can be also a problem, and that one can also be a cause of that significant elevation of the diaphragm. Okay. All right. Now let's move on to the shape of the diaphragm. It is very important to look out for the shape of the diaphragm. The diaphragm always appears dome-shaped. Okay. When we say dome-shaped, let me try and look out for some. Okay. Look at where the cursor is. That's the diaphragm. Okay. That's the right hemidiaphragm, and then the left hemidiaphragm. I hope you can all see it. That's the diaphragm. You see how it is shaped? That's the dome shape. It is having that dome shape. It is not flat. It is kind of dome. So these are the correct shape of the diaphragm. Whenever you see flattening of the diaphragm, you should call in for further assessment to look out for the reason of the flattening. Okay, the diaphragm should not be flat. It should appear just as it is being traced out here. So when there's flattening, it can be as a result of hyperinflation, which may be due to inhalation of foreign body, which goes on to choke the airspace, and then it's causing that hyperinflation in the unaffected lung. Okay, or in a patient who is having a chronic asthma, you can also have that flattening of the diaphragm. And in the case of tension pneumothorax can also cause flattening of the diaphragm. Okay, please, I hope you've understood to this part.
Yes, please.
All right, let's continue. Let's look at the equal lung fields. That's E and F. The lungs appear dark on a chest radiograph. Okay, that's the normal density of the lung. So it means that the lung is an air-containing structure, and that's the appearance or the radiographic density. Always, when we are assessing the lung areas, we should start from the apex or the apices. Apices is for plural, apex singular. Look out for the apices, then you look downwards or you work your way downwards. All right. Always and always, when we are looking at the lung fields, we divide the lungs into 3 zones. Then we compare each zone with the opposite side. Example is here. So this is the lung field, and it is being demarcated or divided into 3 zones. So we have the right upper zone, the left upper zone, the right middle zone, left middle zone, the right lower zone, the left lower zone. And then the height should always be 1/3 the height of the entire lung. All right. The zones will help us to know the location of any pathology if present. All right. However, when we look at the gross anatomy of the lung is divided into lobes instead of zones. But for the purpose of reading a chest radiograph, we always divide the lung into zones. Those who use lobes, they are the senior men. Okay, because it is very difficult and you can confuse the position of a lung or the position of a pathology within a lobe with other lobes, which is very not acceptable. So in order to free ourselves from all the confusion that comes with the loops, we use the zones to do our positioning of the pathologies. All right. Now, we have fissures and then pleura within a lung, right? So fissures, they divide the lungs into loops, okay? Then we have, so for fissures, we have two main types of fissures. We have the major fissure and then the minor fissure, okay? So the minor fissure is seen in both lungs, the left and then the right lungs. Then we have the major fissure is seen in both lungs, and then the minor fissure is seen in the right lung. Or I'm interchanging it. No, the minor fissure is seen only in the right lung, and then the major fissure is seen in both lungs. So the major fissure is the oblique fissure, and then the minor fissure is the horizontal fissure. Okay. So when we look at the right lung is divided into three lobes. We have the upper, the middle, and then the lower lobes. The upper and then the middle lobe is divided by the horizontal fissure. Okay, and then the middle, and then the lower lobe of the right lung is divided by the oblique fissure. When you go to the left lung has two lobes, the upper and then the lower lobes, and it is divided by the oblique fissure. So the oblique fissure is the major fissure, and then the horizontal fissure is the minor fissure. On a chest radiograph, these fissures and pleura, they are not seen unless there is a pathology that is causing them to be conspicuous on the image. Okay, so a pathologist say there is fluid filling the fissure, the areas of the fissures, and then there's fluid filling the pleural space. That's when we can have the pleura being visible on the image. Also, in the case of a pneumothorax, where we can have the pleural line being conspicuous on the lung field, that's when we can see the pleura. Else, the pleura is not seen on a normal X-ray field, as well as the fissure. All right. So, still on the lungs, the lung vessels are also very important to look out for them. The lung vessels should taper and should almost be visible at the peripheries of the lung. So whenever we are seeing absence of lung vessels at the peripheries of the lung, so when we see the peripheries of the lung, these areas, okay, when we are having absence of lung markings, like along there, we are having significant radiolucency within that area, we can suspect the presence of pneumothorax, okay? Yeah. Then also we look out for the costophrenic angles. So the costophrenic angles, just as I said, it is formed by the diaphragm and then the lateral chest wall. They should always be sharp, and the angle formed should be acute. It means that the angle is less than 90 degrees, okay? So when we see that we are losing the sharpness of that angle and then the acuteness of that angle, it means that there's a presence of an abnormality within that area. Mostly, that's the area where effusions are located. Okay, so effusion causes blandness within the costophrenic angles. So it loses its sharpness, and then the acute angle also diminishes. Then let's look at other things that we can see within the lung fields. We can also have chest tubes and other medical devices within the lung area. It is very important to look out for them. Okay, examples, we can have the pacemaker leads in there. We can also see chest tubes. Okay, we can also see other medical devices. All right. So it is very important to look at the lung fields and then rule out anything that is causing the lung to lose its radiolucency. Okay, so when there is a presence of a pathology, it can either come as a result of the area being very radiopaque. When we say radiopaque, it becomes white, or there's a very significant radiolucency. That's very dark areas within the lung areas. These are all things that we have to look out for when we are assessing the lung fields. All right. Please, are we okay with the lung? Please, are we okay with the lung? Hello?
Yes.
Yes, sir.
Yes, sir.
Hello, everyone.
Can I proceed? Can I mute
Okay.
my...
Go ahead, please.
Hello? Can you hear me?
You
Yes,
may
we
go.
can hear you.
You may go on, boss.
Okay. Please, I hope you've understood up to this point.
Yes, please.
All right. So let's move on to... I'm sorry I had a technical hitch, okay? All right, so let's move on. I think we've dealt with the lungs, okay? So now let's look at how to look out for I think, where did we end? We ended somewhere here. All right. All right. G is for gas. So the gastric bubble, that's air within the... Hello?
I can hear you, boss.
Can you hear me?
Yes, please.
All right. So the gastric bubbles, just as I said, that's air within the stomach, okay? And it's always seen underneath the left hemidiaphragm. Here is it. You see this dark area where the cursor is? That's the gastric bubble. And it is always seen underneath the left hemidiaphragm, okay? No air should be seen anywhere else aside the area underneath the left hemidiaphragm. In a situation where we see air underneath the right hemidiaphragm, you should call in for an emergency. That means that the patient is having holoviscos, that's a perforation of the bowel or bowel perforation. Okay, so there should be no air underneath the right hemidiaphragm. However, there should be air underneath the left hemidiaphragm, which is the gastric bubble. All right. Also, it is very important to see or to look at the aortic knuckle, and it should be clearly seen. What is the aortic knuckle? The aortic knuckle is this thing. Let me try and trace it. You see this thing where I have demarcated. That's the aortic knuckle. It should be clearly seen. Okay. And then when you trace the aortic knuckle downwards, that's the descending aorta. All right. When you trace the aortic knuckle downwards, that's the descending aorta. Okay, so the aortic knuckle should always and always be conspicuous on the chest X-ray image, unless they say the patient is having like a pathology that is obscuring the area where we can see the aortic knuckle. All right. Okay. Please, are you okay with that? Your feedbacks are very important. Please, are we okay?
Yes, sir.
All right. So now let's move on to H, which is the hilar and the mediastinum. So hilar for plural and then hilum for singular. All right. The hilum, that's singular. You have to evaluate the size, the position, the shape, and then the density of the hilum. It's very important. Whenever you see enlargement of the hilum, it should tell you that there is something causing that area to be enlarged or causing the hilum to be enlarged. And mostly, these pathologies are mostly lymphadenopathies or lymph node enlargement. Or pathologies concerning the lymph nodes that is causing enlargement of the hilar regions. Okay. I've told you earlier that the lymph nodes around the hilar regions, they are invisible on a chest radiograph. However, in the case where there is a pathology in them, they become enlarged, thereby causing a subsequent increase in the size of the hilum. Okay. Then let's look at the position. The position of the hilum, that is the position of the hilum. We have the right and then the left hilum. Okay. Always and always, the left hilum is a little bit below or lower than the right hilum, or the right hilum is a little bit higher than the left hilum. It's about 1 centimeter difference. Okay. Then the shape. The normal hilum is kind of case-shaped, okay, because mostly the hilum, we have the pulmonary vessels emanating from those areas into the lungs, okay. So the pulmonary vessels, we have those that feed or that supply blood to the superior portions of the lungs, and those that goes to the inferior portions of the lung. These two vasculatures, they give us that demarcations as a key. And that's the reason why we mostly say the hilum is case-shaped. Okay. All right. Okay. So now let's look at the mediastinum. So we look at the mediastinum, we check out for possible widening of the mediastinum. Widening of the mediastinum can be as a result of poor positioning of the patient. That's the reason why it is very important to look at rotation in the technical adequacy assessment. All right. So when the patient is poorly rotated, mostly we can have, so when the patient is poorly positioned and there is rotation in the image, or like the rotation is so significant that it can also result in widening of the mediastinum. Also, other pathologies such as mass can also result in widening of the mediastinum. And in a situation where we have a very massive pleural effusion or a mass within the lungs, it can also cause a shift of the mediastinum, all right, causing all the mediastinal structures to move to the contralateral side. Or we can also have a pathology which will cause a pull of the mediastinal structures to itself. An example is when there is a lung collapse. Okay, so in a situation where the patient is having a lung collapse, we can have the mediastinal structures being pulled towards the area that is being affected or towards the collapsed lung. All right, so we've talked about the trachea being slightly displaced to the right because of the aortic knuckle. Also, when we see a massive deviation of the trachea, just as I said, the trachea, when you see a massive deviation, it can be as a result of poor positioning or a mass, or there is a lung collapse that's causing a pull of the trachea towards itself. All right. So it is very important to assess the hilar region and then mediastinal structures or the mediastinum, rule out for any pathology that is causing the widening, shift, or increase in size of the hilum, or increase in size or distance or the width of the mediastinum. All right. Please, are you okay with that? Hello?
Yes, sir.
Can I proceed?
Yes, please.
Yes, sir.
So this is it. This is the demarcations, the shadings where we can find the mediastinum. Okay, the heart is also within the mediastinum. Then we have other structures. You see where they are being shaded. That's the mediastinum. So when you see a pull, or when you see a push, or when the position of the heart is not within its rightful place, this is the rightful position of the heart. When you see it's being moved from its rightful position, you look out for a reason for the push or pull. Okay. All right, so that's the main reason why you should assess the mediastinum. Then we have S, that's the soft tissue. So you look out for the lateral skin margins, okay? The skin margins that I talked about, and other soft tissue structures around the image. Look out for any foreign body within those skin areas. Look out for any air trapped under the skin or any emphysema within those areas. All right. And also in a female chest radiograph, you can see the breast at the base of the lungs. All right. So you assess all those areas to see whether the patient has had mastectomy before or not. Right, so in the case where the patient has had a mastectomy, you can see one breast very well, like delineated at the base of the lung, while the other is not. That should call in for assessment to tell you that whether the patient has had a mastectomy or not. All right. So this is S, and it is the last part of the alphabet. Okay. So having gone through all the ABCDs and you've gotten to S, it is then that you come in to make your decision, or you make your diagnosis or differential diagnosis for further assessment or follow-ups. Right, so it means that before you can make your decision or diagnosis, you should be able to go through all the ABCD or the alphabet that you've made mention earlier. Right, so that's when you can make your impression or diagnosis, make your differential diagnosis for further medical assessment or checkups, do your you give your recommendations based on what you've seen, and then also give follow-ups. You can tell the patient to go and come a different day to do a follow-up image. But mind you, final diagnosis of the radiograph is not in our hands. It is always in the hands of the referring clinician or the radiologist. All right. So all too soon, we've come to the end of the presentation. And before I hand over to the host, all your questions are welcomed. Thank you and have a great day. Hello, Mr. Host.
Okay, so thank you very much for the time. Most grateful for your time, and we appreciate the time that you've spent with us today. At this point, if there is any question, anybody can bring it up. and he will help us address that. This discussion. Okay, so this is question time. If there's any questions, okay, someone has something to say. Okay.
Okay,
so in the chat, good. Go ahead, please.
All right, so how fluid or water appear on an X-ray? So fluid mostly appear light gray, okay, on an X-ray image. All right. So in a case, example, when the patient is having pleural effusion, all right, we look at the costophrenic angles. We rule out the bluntness of the costophrenic angles. Those images, the fluid in there is light gray. All right. Hello?
Hello?
Hello? Please, did you get me?
Yes, please.
All right.
Yes, I was. I also have a question.
Okay.
So I want to also know how to differentiate between the consolidations that we see in the lung X-rays, especially when one has pneumonia, as compared to the bronchial markings. How are you able to differentiate between the two?
Okay. You see the bronchial markings that you're talking about, they are normal on every X-ray image, okay? However, consolidations are abnormal, just as you said, pneumonia. Consolidations they are areas of increased radiopacities within the lung region, okay? I've told you that the lungs
Okay, so I think the network is not helping, but we are very grateful for the time that you spent here. It's really helped. It has helped to enlighten some of us. Still, if there is any question, we can still have some few minutes, 2 minutes to address those questions, and we call it a day. We will try and find time to deal with specific conditions as well, with examples. Okay, so is there any question? Ibrahim, if you can hear me.
Yes, it's clear. I can hear you now.
Okay, thank you. So can you moderate this section for me, please? We are on question.
Before we move the session to an end, I want to quickly ask Stephen. You talked about when you are reviewing the issue of the chest, it is necessary for you to see or count at least 10 posterior ribs. I don't know if I'm correct with that.
Unfortunately, we don't have him in the room because of his network.
Well, okay, that's fine.
Yes.
Mm-hmm.
Okay, so we would want to end the meeting now and also appreciate your time. We will try as much as possible and find another time so that we can discuss the specific conditions like pneumonia, like cardiomegaly, and all those conditions, tuberculosis and stuff, how it represents on the imaging. We will find another time for that. We will also encourage all of us to subscribe to our channel. This helps us to create similar content and also helps us to know the kind of content that you need. Once again, we appreciate your time, and very good evening to people in Ghana. We had some few people from other Western African countries. We appreciate your time as well.
Mr. CEO, before we sign off, someone just requested for your emails. I think it should be good so that you can get feedback from them. So if you can chat or you can put the email in the chat session for us.
Okay.
Hello?
Hello, Steven.
Yeah. Sorry, my network is very poor here, okay? I'm very, very sorry.
That's fine.
All right.
We just had the concluding remarks from the CEO. I don't know if you have any final words for us before we sign off.
Okay. I want to finish up with the question WAP asked, okay, concerning how to differentiate between consolidation and then the land markings, okay. The land markings, they are normal anatomy on the chest X-ray film, okay. However, consolidations are not, they are abnormal. And how do consolidations come about? Consolidations come as a result of areas of increased radiopacities or whiteness within the lung field. I've told you earlier that the lung is an air-containing structure, and then it means that it appears dark on an X-ray film or just X-ray film. So areas of consolidations, they are areas that are kind of white within the dark areas of the lung. Consolidations, we have some that comes with air bronchograms. So with the example that he gave or she gave with respect to pneumonia, mostly pathology such as pneumonia comes with areas within the consolidations that are having air strands within it, which is the air bronchogram, okay? But you know, we cannot just go in and conclude that the patient is having pneumonia with just the X-ray film. The patient has to go in for lab assessment so that we can finally conclude that, yes, what we were saying about the patient having pneumonia was true. All right, so that's how we can actually differentiate between consolidation and then the land markings. The land markings are normal anatomy in the film. That consolidations are not. Consolidations are areas of opacities within the dark areas of the lung. All right.
Okay, that's fine.
All right. All right. So I want to say thank you once again for giving me this opportunity to share my little knowledge in radiography with you, and I really appreciate it. Right. to thank you, all the team, and then all those who were able to join. I'm grateful.
Okay, for us here, we also extend our warmest appreciation to you. And it's our hope that we will meet again, same time or same platform, so that we pick into details the various physiotherapy-related chest conditions, so that when you are viewing or reviewing an X-ray of such, you can do that with all confidence. So we thank you once again for your time, Stephen. It's a pleasure having you on board.
All right. Thank you too. You're welcome.
Okay.
Thanks for joining, everyone. And thanks to Ibrahim too for moderating this section. We are actually scheduling up, planning to bring another expert on board. We're hoping to get an Indian specialist who is also a physical therapist, but he has specialized in MSK. We are hoping to bring him on board to share his experience with us. If everything goes through, we will share the notice hopefully next week. Thanks very much. Don't forget to subscribe to our channel. This is Michael. Have a good evening.